welcome to the MedEClasses postgraduate lecture series. We'll be focusing today on a very important, although a rare but complicated topic of hypercalcemia. We had this 3-year-old boy who presented with bone pain and had found to have a high level of calcium where the phosphorus was on the normal level. Now, when I discuss about the pathophysiology, we'll understand that calcium and phosphorus, both of them we have to assess in a proper fashion to achieve a right diagnosis in that perspective. Now, on evaluation, now first step you always look at is the PTH level. Now, there the PTH level was low, which was in a way indicated by the phosphorus level, which was normal, because if your PTH is high, you expect the phosphorus level to be on the lower side. So this was a PTH independent form of hypercalcemia. The vitamin D level was found to be normal and calcitriol level was also normal, excluding a vitamin D form. So often we consider, okay, when you have hypercalcemia, you either have a PTH or a vitamin D related cause. Both these causes have been excluded in this scenario. So what we are looking at is a rare scenario. And what was found that there was a lytic lesion which was present in this scenario, which resulted in the diagnosis of a lymphoreticular malignancy, leukemia. So hypercalcemia, though usually endocrine, may also have significant component of other disorders which we have to be aware about, and that's why we need to be cautious about. So over the next hour or so, we're going to focus about the practical aspects of pathophysiology of hypercalcemia, evaluation, management, and case-based assessment. All of you are welcome to go to our website, learning.growsociety.in, which has got a lot of resources with regards to pediatric endocrinology, including a lot of training opportunities which are there. We have got our YouTube channel, which has got a lot of information, along with validated courses on different aspects of pediatric endocrinology, including fellowship programs and the postgraduate programs which are available. We do frequent grand rounds along with the approaches and postgraduate lecture series which we are doing today. There are publications and mobile applications which can be used for day-to-day care.
Three major causes of hypercalcemia. The first one is an increased absorption, which can be because of vitamin D toxicity. It could either be an exogenous increased intake of vitamin D, 24-hydroxylase defect, wherein your 25-OHD is not getting inactivated to 24-25-OHD, and therefore more of it is getting converted to 1,25-hydroxylase and resulting in vitamin D toxicity. Another important cause in the neonatal period is Williams syndrome, which has both these defects. There is a 24-hydroxylase defect as well as an increased 1-alpha-hydroxylase activity resulting in vitamin D toxicity. 1-alpha-hydroxylase excess is also seen in granulomatous conditions like sarcoidosis, tuberculosis, and may be seen in neonates with fat necrosis, as we've already seen. A minor role is played by the kidney, wherein decreased calcium excretion can result in hypercalcemia, which is commonly seen with prolonged thiazide diuretic intake, and a decreased excretion is seen with calcium sensing receptor defect, which could either be because of an inactivating mutation in the calcium sensing receptor or antibodies to the calcium sensing receptor. Moving on, the third cause of hypercalcemia is a disordered bone turnover. Now, it could again be of two types. Either there is less formation, as may be seen with hypophosphatasia or immobilization, or it could be because of increased resorption, as can be seen with hyperparathyroidism, calcium sensing receptor defect, PTH-related peptide defect, and vitamin A excess and thyrotoxicosis, as we've already discussed. In the vitamin D-related causes, in the setting of vitamin D excess, you will see an increased calcium as well as increased phosphorus levels. Vitamin D excess can be because of increased intake. You must have often come across patients wherein you've prescribed them with weekly doses of vitamin D, but they've been giving it daily. So this is a common history that should be elicited to inquire about the frequency of vitamin D that you're giving to the patients. Another cause of vitamin D excess could be a 24-hydroxylase deficiency and granulomatous conditions, which will increase the 1-alpha-hydroxylase activity. A very important cause in the neonatal, especially the preterm babies, is low phosphorus supplementation, especially in those with prolonged total parenteral nutrition. The low phosphorus will trigger 1-alpha-hydroxylase. Therefore, vitamin D levels will be high, calcium will be conserved, resulting in hypercalcemia. But until the phosphorus is supplemented, it will remain low and exacerbate the hypercalcemia.
So generally speaking, you mentioned that in related or vitamin D related causes, we expect the phosphorus to be high. But if the driving force is hypophosphatemia, you will have a low phosphorus level. So don't get confused that if you have low phosphorus, it doesn't mean that calcium is high. The calcium is being driven by low phosphorus.
Granulomatous diseases could be infections like tuberculosis, histoplasmosis, or HIV. It could be inflammatory conditions like sarcoidosis or neoplasms resulting in lytic lesions like a lymphoblastic lymphoma. Classically, these children will have normal 25 OHD levels with very high calcitriol levels. And because this is a vitamin D related cause, you expect them to have normal to high phosphorus levels. Fat necrosis is an important differential one must consider in a neonate with hypercalcemia. The lesions will typically appear like firm violaceous nodules. This is often seen in the setting of birth asphyxia. And again, this has high 1-alpha hydroxylase activity, so you will see normal to high phosphorus and high calcitriol levels. Williams syndrome has a defect in 7q level. The features are it has early onset hypercalcemia, which is often mild and self-limiting. The classical facies described in Williams syndrome is an elfin facies, and they have a higher predisposition to a supravalvular aortic stenosis. The hypercalcemia usually resolves by 4 to 6 weeks here.
So what are the basic cause of hypercalcemia in this disorder?
It is because of 24-hydroxylase deficiency and an increased 1-alpha hydroxylase activity.
If you have less 24-hydroxylase, it basically means that you are not inactivating vitamin D, while you are activating vitamin D more. So these individuals will typically develop symptoms when you actually give them exogenous vitamin D. Once you give that, suddenly their levels will increase. So this is the typical scenario. But as you discussed very nicely, usually you will have facial features and syndromic diagnosis, which is more common. Hypercalcemia is detected when you evaluate. So they are unlikely to present you at that time frame.
Phosphorus deficiency, as we've already seen, it is commonly seen in the setting of preterm neonate on prolonged total parental nutrition, who we have not been able to establish full feeds. Once we are able to put them on full feeds, the dietary phosphorus is usually adequate to meet the dietary requirements. So in the setting of phosphorus deficiency, there is an increased 1-alpha hydroxylase activity. Classically, these children will have low phosphorus with normal 25 OHD and high calcitriol levels. And management is phosphorus supplementation in TPM. Moving on to the drug-induced causes. Drug-induced, the first most important thing is looking at the vitamin D supplementation, whether it has been more than what is prescribed. Other common causes of drug-induced cause of hypercalcemia, one needs to look at vitamin A overdose or thyrotoxicosis. Lithium excess results in calcium sensing receptor defect, inactivating the calcium sensing receptor. Therefore, in this setting, you will see conservation of calcium despite high or high to normal calcium levels. Another interesting thing one sees with calcium sensing receptor defects is that magnesium is also sensed by the same calcium sensing receptor. So this receptor now senses the magnesium levels also as being low or inadequate, and therefore in this setting one may see hypermagnesemia, which is in contrast to hyperparathyroidism, where one will basically have a loss of magnesium in the urine.
So if you are comparing hyperparathyroidism from a familiar benign hypercalcemia, which is the calcium sensing receptor defect, it is the magnesium level which can help you out. If your magnesium is also high, you are more likely dealing with an inactivating calcium sensing receptor defect. While if your magnesium is low, it suggests hyperparathyroidism as a cause. And of course, the other will be the urinary excretion of calcium.
We've already seen increased calcitriol either exogenous or in the setting increased calcitriol intake, and often calcitriol excess may be seen wherein intramuscular injections are given to children to increase their vitamin D levels, which may result in drug-induced hypercalcemia. Infantile hypophosphatasia is a condition of decreased bone formation. So these children will present with early onset hypercalcemia, classically because deposition of calcium and phosphorus in bone is less. So these children will have higher phosphorus levels with suppressed PTH levels. And the diagnostic or the pathognomonic blood test will be low or very low ALP levels in this setting. Chronic immobilization, as may be seen in children with cerebral palsy, usually have reduced bone formation, and like very similar to hyperphosphatasia, they will have hypercalcemia with high phosphorus and suppressed PTH levels. Management involves decreasing calcium and vitamin D supplementation and bisphosphonate, which are basically the anti-absorptive medication.
I think that's a very important point. Is that often patients with cerebral palsy or people who are immobilized, we keep on giving calcium and vitamin D as part of okay, we are trying to ensure that the bone health is good, but that may actually be detrimental. So if you give them too much calcium and vitamin D and they are not using it to form their bones because their muscles are not working, and when we discuss about bone physiology, we know that when muscles are working, sclerostin levels are changed, and that is going to alter your bone formation. These individuals, they don't have muscular activity, their bone formation is reduced. So whatever is happening is that we have got increased resorption and we are not depositing, and that's where the calcium will go up. So you have to be very cautious in that setting.
Hyperparathyroidism basically acts at multiple levels to increase the blood calcium levels. From the bone, it will cause an increased bone turnover, thereby increasing the serum calcium levels. At the level of kidney, it will firstly increase the 1-alpha hydroxylase activity, which will increase calcium reabsorption from the gut, and at the same time, it will decrease calcium loss in the urine.
So all these changes will result in a case of hypercalcemia.
And also PTH is responsible for phosphorus loss. So it will cause hypercalciuria with hypercalcemia with low phosphorus. But because the sir has already mentioned that because your load of calcium delivered to the glomerulus is high, you will also see hypercalciuria, which is a relative hypocalciuria for the degree of hypercalcemia.
So for the same level of calcium, if you have inactivating mutation of the calcium sensing, you will have the least amount of calcium.
Yes.
If you have other causes of hyperparathyroidism, you will have less. If a normal individual develops the same calcium, you will experience much more. So although there is hypercalcemia and hyperparathyroidism, that's not a primary cause, it's secondary to the hypercalcemia. If you corrected hypercalcemia, they will become hypocalcemia. That's important.
And because of the increased bone turnover, it results in metabolic bone disease. So increased PTH effect can be because of hyperparathyroidism, which could be isolated as seen in CD73, menin and calcium sensing receptor defects. It could be part of syndrome, especially MEN syndrome. MEN1 is has 90%, like 90% cases of MEN1 will have primary hyperparathyroidism. 20 to 30 patients of MEN2A will have hyperparathyroidism. MEN2B almost never has hyperparathyroidism. Other causes are MEN4 and cyclin-dependent kinase 1B defect, or it could be hyperparathyroidism, which is sporadic, as seen in other, certain genetic defects.
I think one important point to remember here is that as against adults who are more likely to have an isolated lesion, which may be because of a somatic mutation, children and adolescents typically below around 30 to 40 years of age have more likelihood of having the genetic causes, which are more likely to be multifocal.
Yes.
And that's important because if you have a multifocal lesion, getting a scan and picking up one lesion and removing may not cure the disease, it will come back again. So that is something which is important to remember.
Increased PTH effect can be because of a sensing defect as seen with calcium sensing receptor mutation or antibodies in antibodies to the calcium sensing receptor. It may be also seen with familial benign hypercalcemia, which may be because of different genetic causes.
Very important to identify this is because even if you do a parathyroid surgery, earlier people used to do is that okay, you have hyperparathyroidism, PTH is high, and you've got high calcium, remove the parathyroid. Would the removal of parathyroid result in remission of hypercalcemia in this form, calcium sensing receptor defect?
No, these are often asymptomatic because
So
they
one,
have.
it's benign, and second, the other mechanism is your decreased renal excretion will persist. So you will not be able to cure their hypercalcemia. So these ones will be picked up on routine clinical assessment with marginally elevated calcium levels. Don't do much in this segment.
Or increased PTH effect, maybe because of increased sensitization, as is seen with constitutionally active PTH1 receptor in Jansen's metaphyseal dysostosis, PTH-related peptide increase in Wilms tumor, and increased GNAS, constitutional GNS activity in McCune-Albright syndrome. An important and a severe form of neonatal hyperparathyroidism is seen with calcium sensing receptor mutation when both the parents are affected, either a homozygous mutation in child or a compound heterozygous mutation in the child, will result in severe hyperparathyroidism. Often the levels go up to 15, 16 levels mg per deciliter. It is an inactivating calcium sensing receptor in the 3q chromosome. And here it results in shift of the calcium PTH curve to the right. These neonates present with severe hypercalcemia, with relative hypercalciuria and a high magnesium.
This is a very important point to remember is that often you will not see features of nephrocalcinosis and all because the calcium sensing receptor is defective. But if your levels are going like 20 and above, the filtered load is so much that you may still develop these features in that regard. So major presentation is in the newborn period with dehydration, failure to thrive. Those features are more common in that setting.
Since there is a receptor mutation, your PTH levels are also high. So despite hypercalcemia, there is an increased bone resorption resulting in fractures and metabolic bone disease. Here one may consider, one has to go for a family screening. In the setting of such severe hypercalcemia, hydration furosemide, which is basically a hypercalciuric drug, short-term cinacalcet is important, but the long-term or final step is the parathyroid surgery. Post-surgery, these children will have hungry bone syndrome, and therefore calcium vitamin D supplementation is essential in the post-op period. The benign form is the calcium sensing receptor mutation heterozygous. These individuals will have hypercalcemia with hypocalciuria. Because they have hypocalciuria, they will often not have polyuria dehydration symptoms. And
so these are the milder forms. And often the problem is that you don't want to overdiagnose these individuals and subject them to surgery. Because if a surgery is done, that is going to cause more problem and confusion. It's not going to solve the problem. So this will be the milder form.
So these individuals will often not come with any presenting symptoms. They will be picked up on routine screening and will not benefit with parathyroidectomy.
So the important thing to identify this condition is when you have a neonate who is presenting to you with the severe hypercalcemia, get the urine and blood calcium checked in the parents. If both parents have hypercalcemia and hypocalciuria, you are most likely dealing with a heterozygous compound heterozygous or a homozygous, a severe form where surgery and parathyroid removal is required. But if you are dealing with a situation where only father has hypercalcemia and hypocalciuria and mother is normal, this could be a transient scenario because this defect has come from the father and the baby was sensing the mother's calcium level is low. Now we always talk about the reciprocity in terms of the maternal level and the fetal level. So if the mother's sugars are high, baby sugar will become low. That is the infantodiabetic mother because of the homeostatic mechanism. Similarly, long-standing, I think that's one we did not include here, is that if there's a long-standing deficiency of calcium in the mother because of hypoparathyroidism or in the setting of vitamin D deficiency, the baby will sense that calcium low, produce more PTH and will develop hypercalcemia later. This is a very interesting scenario where the mother is normal, the calcium is normal, but that normal calcium is sensed as low by the baby because he has acquired the mutation from the father. And there will be a hypercalcemia with hypocalciuria, which will improve over time as things will settle down from that regard. So that's an important differential to look at.
As they have calcium sensing receptor mutation, and the receptor also senses magnesium levels. So these children will classically have higher magnesium levels, normal to high PTH levels. Because of hypocalciuria, they will not develop polyuric symptoms or dehydration and will have no renal calcification. And again, no increased bone turnover or metabolic bone disorder.
Is that you should suspect hypercalcemia in a child who's acutely sick, particularly if there's dehydration, constipation, abdominal pain, hypertension. Get a calcium level done. If your calcium levels is high, always check PTH levels simultaneously. If your calcium is high and PTH is about 20, it is hyperparathyroidism. Start working in that regard. Look for urinary calcium to differentiate familial benign hypercalcemia from hyperparathyroidism. If your PTH level is under 20, look for vitamin D levels. If they are high, it's usually iatrogenic. If vitamin D is normal, look for calcitriol. That will indicate more towards the possibility of granulomatous disease or increased conversion. If both PTH, vitamin D and calcitriol, they are all normal, think of an increased bone resorption scenario like immobilization, hypophosphatemia, malignancy in that setting. So identification of hypercalcemia is very, very important. At this point of time, I'd like to thank all of you for patient hearing, and all of you can go and have a look at our website, learning.society.in, with validated courses related to pediatric endocrinology.